Welcome to Dr. Hood's Helping Others Overcome Determinants visits types as a clinical research coordinator or as a clinical research associate training. So the purpose of this training is to just to give an overview on visit types the coordinator will conduct and visit types that the CRA will conduct. So on the agenda, we're going to do an introduction of the host. That would be me, the introduction of the group. We got a slide on the acronyms that will be used during this presentation. The types of subject visits related to the study coordinator. We're going to take a 5 to 10 minute break. Then we're going to go over the type of monitoring visits. Then we're going to take a 5 question quiz. Then we're going to review some takeaways from the training. And then you all have the opportunity to ask any questions. Although in between slides, you can definitely interrupt and ask questions, and then at the end it will show some social media platforms that the training will be uploaded to. Okay, so Dr. Kentress Davison, that's me. I graduated from high school in 2002. I went on to college at the University of Alabama at Birmingham and got my biology degree. I got a master's degree in clinical research administration in 2016, and then in 2023, I completed my doctorate of public health. ProQuest is where my dissertation is, if anybody is interested in reading the dissertation, but the title was Risk Factors of Human Papillomavirus Positive and Oropharyngeal Cancer in Men. I hold a certification in medical assistance. I got that in 2014. My career started out as a patient care tech. I did approximately 6 years at UAB, University of Birmingham, Alabama, at Birmingham Hospital. Then I went on to their clinic, which was the Kirkland Clinic, and was the lead PCT and ENT. And then I transitioned from that to become a research encounter specialist, where we primarily did the scheduling and insurance pre-certifications for subjects coming in. Did that for a year. And then I entered clinical research in 2011. So I was a study coordinator for almost 10 years. My background was diabetes and endocrinology disorders. And then I became a monitor in 2021. Started out at one company, did them for approximately 10 months, and now I've been at the company I am now for approximately 3 years. And in 2025, in March, that's when I started Dr.HOOD, Helping Others Overcome Determinants, LLC. Okay, so now we're going to take this opportunity for you all to introduce yourself. You can just provide your name, the state that you're in, your current role or your desired role, and your favorite sport to watch or play. Either one of you can go first.
Well, if nobody else is starting, I'll go first. So first of all, thank you for doing this for us, Kentress. I'm excited to see what you have to say. My name is Alex Van Hoof. I'm a MD. I graduated about a year ago, and prior to that, I had some experience as a clinical research coordinator. And right now, I'm looking to use my experience to kind of move into a role in a CRO. So I'm hoping to gain a little bit of knowledge about that.
Okay. Next person.
I like football, by the way. Sorry about that.
To play or to watch, or both?
I've done a little of both, but at this point, I should probably stick to watching.
Okay.
So I can go next. So hi, Keeper Richards. So I am currently based in Maryland. So I have been in clinical research for a little over 5 years now. I am desiring to become a CRA and move into middle management, whether it's a CTM or CRM. I wouldn't say necessarily I have a favorite sport. I'm very girly. I used to play what we call football in my culture, but for America, it's soccer.
Soccer.
So I will pick soccer.
Okay. And last but not least, are you there? Okay, moving on. Maybe you had to step away for a minute. Okay, so we're gonna minimize that again.
Yes.
Okay, there you go.
Yes, here it is night. Good evening. My name is
Hey.
Aspan Askea. I'm from Kenya.
Okay.
I can say my background is I am a laboratory scientist and also working towards moving to be a CRA.
Okay.
because I've attended trainings and I'm working towards becoming a CRA. Thank you.
Okay. So, so the beginning of this presentation is going to be kind of like the visits on site, but since it appears that most people want to be a CRA, we'll kind to, like I said, do a quick overview, and then we'll dive a little bit deeper into the roles that's related to the CRA. Okay, so these are some acronyms. Of course, I'm not going to go over all of them, but clinical research is full of acronyms. So the faster you learn what things mean, the better off that you will be. So we got the CRC, that's the clinical research coordinator, the CRA, the clinical research associate, the CRO, the clinical research organization. You got the PI, which is the principal investigator. It's down here. These are the abbreviations for some of the systems. So electronic trial master file, electronic data capture, what we call EDC. You all may be familiar with systems like Metadata Rave or Inform or Oracle. Those are what we call the electronic data capture systems. Our CTMS systems, you might be familiar with Creo or RedCap or what's some other ones? eClinical. So those are the type of systems that the site usually uses to chart their information. ISF, that's like the driving force of what CRAs are responsible for when they come in to do interim monitoring visits. We have to make sure that the informed consent process is being done in the right way. The investigator site file is where the site stores all the documentation. This can be a physical binder or it can also be electronic. So, once we start conducting visits as a CRA, we'll find out how the site stores that information. We over here, we have adverse events, AEs, SAEs, serious adverse events. Do anybody know the difference between the two as far as reporting? What's the timeline between an adverse event and a serious adverse event?
I believe the timeline difference, so a serious adverse event within 24 hours of the site being notified. So not of when the event occurs, you have to report it.
And that is absolutely correct. And based on the site uses of the alternative review board, the IRB, some serious adverse events have to be reported to them as well. Not all of them. So you have to read their criteria to find out which ones need to be reported. But it's usually the ones that's related to the investigative product. So if the PI feels that this serious adverse event occurred because of the drug, then that needs to be reported to the IRB. Also, pregnancies needs to be reported to the IRB, and anytime the subject unfortunately has a death. But the rest of the criteria, you can review their handbook and determine if it needs to be reported to the IRB. And their typical timeline, I believe, is 14 calendar days, 10 business days. But of course, that would be in their handbook as well. Just some other words. We got the letter of intent, confidentiality agreement, feasibility questionnaire, and then these are your type of your CRA visits. We have the site qualification visit, site initiation visit, a booster visit, and interim monitoring visit, a termination visit, or closeout visit. Those are some of the common visits for a CRA. Okay. So visit types for the site. So this first one is pop-up. This is not a true visit, but if you are a coordinator, you probably experienced this situation where you're in the middle of something, then the PI calls you and say, hey, I got a patient in clinic. They might be interested in clinical trial. I need you to come over and explain it to them. So that's what I call the pop-up visit. So it's not really part of the protocol, but it might be part of the site's process of getting subjects in. So you have to pop into the clinic, or you might be already in the clinic, but the PI just sees a potential patient through their standard care practice, and they want you to present the clinical trial to that individual. The screening visit is the visit where, okay, the subject has agreed to participate. You're going to provide them with that informed consent. give them an opportunity to read over it, ask any questions that they may have. Sign it, of course. You need to provide them with the signed copy. Um, and then you'll complete the assessments of the visit per the protocol. The running period, not all clinical research trials have a running period, but this is a situation where you can have this type of visit, and it's when the study participant has passed all the screening procedures, but either the drug is real sensitive, or it has a lot of adverse events, or it's very expensive, whatever the reason why the sponsor has decided to do a running period. Basically the reason is for compliance. They want to give the subject a brief window. It might be over 1 week, 2 weeks, 3 weeks, whatever they define, just to make sure that you have picked the subject that's going to be compliant of how to take the drug and when to take the drug. Once they have completed that process and they have achieved compliance, you have what's called the baseline visit, or day one. Go ahead.
Yes, I do have a question. Max, which therapeutic areas do you typically see a run-in period in? Like I've worked in oncology, but typically those drugs are very expensive and sensitive, but I've never seen a run-in period, or maybe we just never called it that. So is there
So in my 10 years as a coordinator, we only had two, and it was for methotrexate. It was actually being used, they used it for rheumatoid arthritis and those type of conditions, but they were using it for another indication. And I want to say it was a cardiac outcome study. Um, but don't hold me to it. But I want to say that it was dealing with cardiac outcome, hyperlipidemia, I believe it was. So they had a running period for that one, and then I've had one to have a running period for a diabetes medication as well.
Thank you.
And well, I'll ask that question when we get to the other page. Okay, so baseline is, or day one. It also can be called the randomization visit. This is the visit where, okay, the subject has passed the screening process. If a run-in period was applicable, they'll pass that as well, and now they're going to be randomized to a study arm, whether there's placebo or the investigational product or comparator, whatever the cohort is for the protocol. Now they're going to be randomized. Then we have what's called the maintenance and the treatment phase. So these are the visits after the baseline visit, and they are predetermined by the protocol. So they might be, the first few visits every 2 weeks, and then you're going to go to every month, and every 3 months, and every 6 months. However the study is designed, it's just the period in which the subject is going to be taking an investigational drug. Then you got an end of treatment, you got the end of study, the unscheduled visit, and the illness or home visit. Okay. So I'll swap y'all over to this side. Okay, so the pop-up. So again, this is not a formal visit, but if you are currently in a participant recruitment phase, it's just when you'll come over and to introduce the study to a potential client. The screening, again, is just when the participant is more interested in the trial and is willing to participate. You collect their initial information, including medical history. Now, it's important to know whether or not the protocol requires actual medical records, or they're going to accept patient reporting. So for some protocols, especially if it's a rare disease or they have to have specific mutation, they want that from their medical records. They don't typically want to just go off patient reported. Yes, I have this. They want to see it in writing. When there is a specific drug that they need to be on for a period of time before they can be enrolled in the study. They also would like the concrete medical history of that, whether it's the actual clinic note or you can get a list from your pharmacist. They want something other than the patient reported. So make sure as a study coordinator that you know whether or not patient reported is acceptable or not. During this time, the screening visit, you might want to go be proactive and have the subject sign the medical release form. So again, so you can get those medical records. You're going to perform visit assessments, ensure that the person signs the consent. Okay, then the run-in period, just like again, is not required, it's not common. However, it may be appropriate as a part of a visit during a clinical trial. The subject will undergo a period during which a placebo active drug is administered, and we're checking for compliance. Now, it is important that the PI checks off everything that was required before the screening visit, before the patient enters the run-in period, because you don't want a patient getting unnecessarily introduced into the run-in period if they did not pass the screening process. Okay? So check your knowledge. Anything wrong with the order of assessments in question 2? So you can start with you collect. Anything you notice that might be out of order with the screening visit, what should go first? Go ahead.
Before anything is done, consent needs to be obtained.
Correct. So I purposely put that at the end to see if we would catch that. It is so important to make sure they document the informed consent process. They need to, so you have the actual consent where the subject signs, and then the site should create what's called the source informed consent source. So that says that you gave the patient applicable amount of time to decide to participate. You answer their questions if they had them. You provide them with a copy, but it's important to document that time. So because as a CRA, if I don't know the time that the person signed the consent, I can't really verify that it was done before the assessments were done. So it's important now that sites document the time that the subject signed their consent form. Any other questions about these 3 visits before we move on?
Yeah, Kentris, one thing I was just curious about here is when you're talking about this pop-up in the screening visit, I mean, do they have to be separate visits? I mean, in my mind, I'm thinking if I'm sitting there as a coordinator and I have access to the schedule, I can identify ahead of time patients that might qualify for this trial and reach out to the PI or another provider who's acting as a sub-I, and I identify them.
Yes, so that is correct. They don't have to be separate, but reason why I put them separate, some IRBs require that you give the patient at least 24 hours to read the consent. So, unless that has been waived, that's why I made them separate, but they do not have to be. If you're not under IRB that requires that they need at least 24 hours to have the consent form before you can proceed, then you can go ahead and complete the screening visit at the same time. Okay, so the baseline day 1 randomization. This is a pivot visit because, again, the patient is being randomized to the study arm. It is so important to have the right information in the system. Say, for instance, you're doing a study and the study arm is based on age. You got an adolescent group, you got a 18 to 65 group, and then you got a 65 to older group. And based on their age group is going to be the dosage that they might receive. Those you need to make sure as a study coordinator that you enter that date of birth correctly and what's called the interactive web response system, IWRS, or the interactive response technology system, the IRT. Because we get a lot of discrepancies that patients was randomized to the wrong arm because whatever data that was required to put in before you hit that randomization button, it was not done correctly. So I just wanted to point that out. Also, what the CRA should be looking for is when they conduct this visit is that the PI signed off on the screening labs, the medical history, the concomitant medications, the inclusion exclusion checklist before the subject has been randomized. So if you see that the subject was randomized June 6th, but the PI didn't sign off on those things until maybe June 8th. What would you say that the PI has violated? Two things really, but what would you say the PI has violated? Go ahead.
I don't know if this is the right term, but from my terminology, you want to make sure that they are truly following the inclusion criteria, no exclusion criteria is being met, and just
hmm
safety
So
compliance.
that will be found in the what?
That come on out of these two systems,
Yeah, well, the inclusion exclusion will be found in the what?
the protocol.
The protocol. So if they don't do it prior, then the subject is randomized. They have potentially run the risk of a protocol deviation. And also, oh, go ahead. See if you're going to get the second one. Doc, you're unmuted.
Oh no, sorry. I was gonna say protocol violation, but that's not even the right term. So
Yeah, protocol deviation is the right term. And then the other one is good clinical practice. You know, he's not or she's not demonstrating good clinical practice if they review those conditions after the patient has randomized because you may have put the patient in a potential safety issue. If their kidney functioning has to be a certain value and you randomize them because it's known that this drug is going to affect the kidneys and their value was too low, you know, you created a safety issue. So that is why it's important that we make sure. Now it doesn't they prefer it to be the PI, but it can be a sub-I if they're medically qualified. So it can be the sub-I, but sponsors prefer randomization kind of being overlooked by the PIs. Okay, so the maintenance and treatment phase. Go ahead.
Do you mind if I ask a quick question? Yeah. So,
Not
and
at
this
all.
might be a little bit of a ticky-tacky question, so my apologies. But so, I mean, I can envision a situation where, let's say, like the investigator, right, or the clinician who's overseeing this patient, right? They reviewed the labs. You spoke to them verbally as the coordinator, right? Or said, "Oh, the labs are great. You know, that's fine, right?" But obviously, as far as the documentation goes, like you have that day, right? They have to be signing off their signature and their date on the lab saying, "Hey, this is qualified, needs to be ahead of time." Let's say somehow this provider is like, I'm going to sign them right now, and then they don't, right? So now they've approved these labs, right?
Mhm.
And verbally, they've looked at them, right? But now all of a sudden, after the fact, you're realizing, oh, they forgot to sign them. How does that get handled?
Okay, so it needs to be handled. It can be handled in the progress note. Now
Right.
it does not just it will not negate that the CRA can write a protocol deviation or they can write a deem you on good clinical practices. But at least if the study coordinator wrote in or the PI wrote in the progress note, I reviewed the labs, I reviewed the inclusion criteria, and I gave the study coordinator the go ahead to randomize. Okay, that's good. But if it's not documented, it's not done. So we don't want the dates to be after the fact. Now, if it's later that day, I mean, the CRA doesn't know the time point. But if it's a different day, you know, that deviation or that GCP ding is still going to take place.
Right. Okay. Thank you.
But to come, but it will be good to see in a progress note that the study coordinator acknowledged that discussion took place and they were given permission to randomize. And I'm gonna be honest with you, some protocols do not have a physical exam due on the randomization date. They have it on the screening visit. And so the PI or the sub-I might not even be physically required to be there at randomization. So this is where the PI judgment comes in. Do I want a medically qualified person there at the randomization, despite what the protocol says? Or, do I have a progress note already in the chart saying, I reviewed this such and such date, and I gave that coordinator the opportunity to randomize that subject. So you have a lot of protocol. We, as a diabetes research, we had a lot of protocols that the doctor saw the patient at screening and they saw the patient at closeout. Unless they had an AE, they didn't see him again. So, per protocol, me as a coordinator, that didn't really jive with me. So I tried to still, have my visits where the PI was least on site every other visit. So in the event something did come up, I can pull them out of their standard care visit. And, hey, this person is having an issue. So that's a standard of operation decision in that scenario. Go ahead with your question.
I actually just wanted to add something. I know to prevent PIs not signing documents, I know how I was trained, so I came from the academic world. We always printed off labs and had the PI sign before we was heard.
Oh yeah, they should already be printed off and placed in the subject's chart. And again, if the site is not doing paper, they should already be scanned into the subject's chart. So at least if we, because usually, well, not usually, you're supposed to be a time stamp on when stuff is scanned in and that sort of thing. So at least if you can show that it was scanned in prior to randomization, that'll be a good look as well. Okay, so the maintenance and treatment phase. So this is just the visits that the study coordinator will conduct per protocol that keeps providing the study drug. So the patient might get it every visit, every other visit, but whenever sometimes the protocol might say that they should take medicine out of their current bottle the day before and take medicine out of their new bottle while on site. Some protocols are set up where the bottle that they bring in, they take the last dose from that bottle and then they get a new bottle to start the next day, or a new injection, whatever the investigator product is. So you want to make sure, because this is another issue where non-compliance is frequently found. When do they stop their current bottle and when do they start taking meds out their new bottle? So make sure that protocol, you understand that protocol procedure, because what happens is throws off the count, it throws off drug accountability, and it also might pose a safety issue. Because say, for instance, the subject has been titrated. They start off with a dose, and then based on their tolerability, that dose increases or decreases. So if you gave them a drug that morning, and that drug gives them an upset stomach, and per protocol the dose should be decreased, that dose for that day is now a protocol deviation. And depending on the criteria, the IRB and the protocol, it might also be considered a medical error or medication error that needs to be reported to the IRB. So it is very important to be compliant. I would also suggest some type of kit verification. So a lot of protocols are not designed where two people has to verify the kits. But this is what I was talking about when I said I'll talk to you about it later. It happened to me in a run-in period. Thank God the run-in medication was placebo. So all the pill kits were the same. I had imposed the last two numbers, so I can't remember what they were, but I'm gonna just say it should have been 15 and I handed them to 51. And I didn't realize until they brought the pill back. It didn't match the IRT confirmation slip. Now I could have hoped that enough patients would have came in and nobody would have figured it out, but that's not the way to handle that. I had to report it to the IRB. I had to report it to my PI. I had to let the patient know. that they had did not have the correct kit, and I had to document that. My saving grace was it was not considered so much a safety issue because all the drug was placebo. So what? But I did have to go back into IRT and do what's called a data correction form. Um, and I had to indicate that I gave the patient this kit number versus that kit number. And the reason why I had to do that because now the right kit is no longer available, and the kit number that they should have had is now available. So this is why I had to do the data correction form. So it's a lot of steps when you mess up medication. It needs to be reported to the PI. We need to assess the patient for safety. We need to report it to the CRO. So I had to report it to my monitor at the time, and I had to report it to the IRB. So after that, there was no more of that. What I started doing with the IRT confirmation, I gave it to the patient. They had to call the pill bottle numbers off to me, and then we swapped. I had the paper, or they had the bottle, and they had to call the numbers off to me. And so I implemented that until we got another coordinator to make sure that that did not happen again. Okay, visit 6. Okay. In a
Is that,
treatment visit.
I was just wondering, is there any way, like in a situation like to me, what I'm hearing from that situation is right. Why would that not be part of the protocol design, right? Because it seems silly to like that's an easily avoidable situation if they just write in have another human being check this number because humans make mistakes, right? So in that situation, is there any sort of like way to relay that sort of
So in
situation back
some
to the team to maybe modify the protocol? Because that's a to me that I'm hearing okay, whoever designed this protocol probably didn't have on-site experience because they would have understood that that should be something outlined, you know?
so a lot of protocols are not written where you have to verify, two-party verification. They lead that up to the site to practice good clinical practice and implement some type of standard of operation within themselves. But you do have, like the study I'm on in my 9 to 5, their documentation sheets does have a verifier. So one person prepares the IP and the other person has to verify. The person that verify can give the dose, but I want to make sure I get this right. But they wanted to always be the same two people. So if the person who watched you prepare the drug, they want that to be those same two people going to administer the drug. They don't want a person to watch you prepare the drug and then you grab somebody else to administer the drug. They want the same two people to be either the verifier and the preparer, and the same two people to be the person that administer the drug and the verifier. So it just all depends on the protocol. But again, when it's not part of the protocol, they rely on the site to have some type of SOP in place to prevent medication errors. And that could be a question that they might ask during the site initiation visit, and that could be a question that's on the checklist for the qualification visit. So it just depends on um, dangerous or how many side effects what's the risk, I should say, of the study medications. Just depends on if the medication is high risk, then usually they have a verification process within the protocol. But that was a good question. Okay, visit 6 types. We got the end of treatment. This phase, which may be a single visit or extended over multiple visits, is a critical part of the trial's conclusion. It's a period of follow-up visits where the participant has ceased using the investigational product, either as per protocol or at the participant's or principal investigation's discretion. Still, the PI continues to monitor the health and the patient's safety. So we have 2 scenarios here where you do end of treatment. Again, it can be a part of the protocol. They might say, okay, the patient is only going to take the drug for 6 months, and then 6 months we want to monitor them. So that is that visit when they took their reporting their last dose. It is the end of treatment phase. We also have a scenario where the PI says, hey, this patient is non-compliant. I'm concerned about their safety. I'm concerned about the data quality. So I want to approach the medical monitor and the sponsor to see if we can stop the medication, and the patient just continue to complete the visits, and we just gather concomitant meds, adverse events, and that sort of thing. Um, so check your knowledge. Can the site continue to complete end of treatment visits if the subject has withdrawn their consent? Go ahead.
I will say yes. In my experience, now it's not something you can force them to do, but we highly recommend it. Again, I know when I have done that with participants, I phrase it as for their safety, to not only complete the end of the treatment visit, but we would like to do follow-up visits with you, especially if you're an investigational product, and explaining to them, you are having a drug or product introduced into your body, and you want to make sure that we follow you to make sure that you are safe. Also, depending if they are a person who can become pregnant or a person who can get someone pregnant, just explain those safety parameters to them. So that's why I would say yes.
Okay. Anybody else want to provide a different outtake?
No, I don't have a different opinion. I think the safety element is definitely what she mentioned is probably the biggest thing. I mean, this provider is probably going to continue to see this person, so it almost seems irresponsible to not also document along the way if possible, right?
Okay. So actually, if the patient has withdrawn consent, you cannot continue to follow them. If they have withdrawn treatment, you can continue to follow them. So that's why I asked the question. I want to make sure you guys understood. When a subject withdraw consent, they say, "Hey, my hands are tied. I don't want anything else to do with this," for whatever reason. And you want to document that reason. um you um you want to document that you gave them the option. Hey, although you're not interested in the taking the study medication anymore, we would like to continue to follow you for safety checks. Will you be willing to do phone calls or come into the visit where we just go over your comments and your draw labs, that sort of thing. They can consent to that, and you need to have documentation. Hey, the patient is withdrawn from the IP, which is the end of treatment, but they are willing to do safety checks. That's what that scenario is. If they withdraw consent, you want to document the reason. And it can be just, I don't want to participate anymore. But you need to document that reason. Same on with the scenario. Provide a scenario where the participant may want to stop. We kind of already went over that, or the PI may prevent the IP from continuing. Give me a scenario. I mean, I've said it, but I just, again, knowledge check. Give me a scenario where the PI might want to stop the drug.
I mean, as far as where the PI is going to stop the drug, I mean, a safety issue is right. Like, let's say the person starts to have sort of deleterious like effects from the medication, or starts to no longer the PI starts to feel it's no.
You froze on us, but I think the overall legit. So what you were saying is for safety reasons, and that is correct. Okay, now we got that unscheduled. I think we were kind of wrapping up the end of study. The takeaway was just if the patient had any critical values or SAEs, we need to follow up per either good clinical practice or the study protocol. Okay, we got those. What happened there? Unscheduled visits. Self-explanatory. We bring patient in that's, outside of the window of the protocol. Typically, we do these to assess AEs or SAEs. They called us and let us know that they experienced either one of those situations, and their next visit is 3 or 4 months out. We don't want to wait that long to kind of follow up with the patient. So, good clinical practice will be to bring that patient in to assess what's going on. Also at that time, if the initial medical release form that they have signed has expired, you might want to get them to sign another one so we can get those medical records related to that SAE. Um, or AE if they had to go to a urgent care or their PCP because of it. You want to keep those in the charts for the PI's reference. That should help him or her determine if the AE is related to the IP or not. We also can bring a patient in for an unscheduled visit for a redraw or to get a lab. So if they was just very dehydrated on that scheduled visit and you couldn't um, get any blood to come in, you can bring him in the next day or next couple of days to get that lab. Now, depending on the protocol, you might still be able to use the kit associated with that visit versus using an unscheduled visit kit. So in those scenarios, if they came in for week 2, visit 3, and you were unable to draw their blood, but they came in the next day, typically you want to use that same kit. You just need to put in a progress note or the comment section of that requisition form as to why the visit day and the lab collection day does not match. But typically the protocol does not want you to pull that unscheduled kit and when the blood draw is so close, it's the next day. So that's and sometimes unscheduled visits also can take place if you just need to re-educate the patient on compliance. If they are supposed to do their e-diary 5 days a week and they're only doing it 2, bring them in. Let's go over the e-diary process again. Let's, if they get a email prompt or text message prompt, make sure that they know how to get to their email or their text message within the device that you have provided. So unscheduled visits can also be for re-education. So whatever the PI deems, and typically when you do an unscheduled visit and you go to chart it in the system, there's a checklist. So if you did not recollect labs, if you did not do vital signs, whatever you did not do, make sure you specify that in that checklist. You only want to document in the EDC system the tasks in which you actually did. Okay, so now we got visit 9. Now we have visit 9. Put y'all back at the bottom. Okay, not all visits windows will have these types. A lot of protocols don't have these types. But again, dealing with vaccine studies, we did have a visit type called the illness visit. And that is if the patient exhibited some symptoms regarding the indication that we were following up. They had within 72 hours to come into the clinic so we can do necessary testing, swabs, lab draw, and PI physical exam. So, like again, 9 times out of 10, you won't have this visit type, but if you do, this is what an illness visit is if they're studying a particular indication that they want you to bring the patient back if they have exhibited those symptoms, you need to follow the protocol, whatever window that is. Home visit, it's self-explanatory. There's some studies that are set up where the patient can do home visits versus to have to come in. A lot of these times, these are set for people who have rare conditions. A lot of times, if you have a rare condition, you don't have a readily clinical site to see you. So instead of you having to drive 3 and 4 hours for every visit or fly for every visit, even though you're participating in that site in a different area or a different state, they designed the protocol where some of those visits can be conducted at home. So they'll partner with the home health agency. That home health nurse or study coordinator will go out to that person's house, and they'll conduct the visit. And then they'll scan in the source documents to the primary study coordinator.